close to each other. Then second is penetration. Then resolution is what? You stand on a highway in the night when the car is approaching towards you. When the car is approaching towards you, they look like a blob. And once they come closer to you, you can say, look, this is the size of the headlights. This is the distance between those headlights are. And that makes a difference. Look, this is our best resolution. If we don't have a good resolution, we can't identify the images. We can't make definite diagnosis. Next word comes penetration. Penetration is depth. For example, if you have a newborn, his heart lies very close to chest wall. So we don't need penetration. If you have an adult population person, his heart is almost 10 to 15 centimeters inside the heart, inside the chest. So we need penetrations. And based on these two, resolution and penetrations, we have frequency of a transducers. Lower frequency means 2.5 megahertz of a transducer. 10 megahertz means higher frequency. What is the characteristic of these transducer is? Lower frequency, they have a better penetration. Poor near resolution, good Doppler studies. If I put these points together, this transducer would be good for elderly population, middle-aged population. Higher frequency transducer means they have a poor penetration, higher definition of cardiac structures, but poor Doppler studies. So it'd be good for neonates or pediatric populations. We were not happy with this lower and higher frequency transducer. So what exactly we did? We started looking for a broadband transducers, and the word came up as harmonic imaging. This they coined as single harmonic imagings, 2.5. And then we use from 2 to 4 megahertz, that is known as double harmonic imagings. What is the importance of these two differences were? If I use a transducer which has got a harmonic technology, belongs to 2 megahertz, and it is scanning from 2 to 4 megahertz of a transducer. So at 2 megahertz, it's scanning at a distant part. Good Doppler study, good penetration. For more 4 megahertz, it's scanning at the nearer parts. So whole of the resolution of images goes up dramatically. So all in one is a transducer, which is harmonic imaging transducers. And this is what has stayed in today's practice. If somebody is trying to sell you a non-harmonic transducer, it's trying to sell you a system, DOS in the era of I3, I7, I9. Then footprint of a transducer. Footprint is the place or the head of a transducer which we touch to the chest of the patient. All of us understand we need to have such a transducer footprint which can insunate in between intercostal spaces. Neonates, very small footprints. Adult, medium size. And I saw a number of times my colleague doing an echocardiography with a ultrasound abdominal probes, which cannot insulate in between intercostal spaces. So we need to have an adequate footprint of these transducers. Just a word is no more used as a historical transducer. It is what? This is a single PDOF crystal transducer. There was an era we never used to have a continuous wave Dopplers. So this is a blind continuous Doppler which was available long back. We have given it up completely. So we started with single oscillating crystal transducer. Then we went on to rotating transducer. We came up to annular phase array transducer. Then we came to linear phase array transducers. And now this is what we are standing with. Anybody less than broadband linear phase array technology is buying all these things that are obsoletes. And if you have money, you can go and buy a multi-planar or a 3 dimensions transducers. One word about linear phase array transducer. What do we mean by linear? Well, this is a number of piezoelectric crystals which are lined on these transducer and they fire in sequential fashion. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So thousands of crystals they are firing at regular intervals. Some of them they're sending images, other ones are receiving images. So they're doing multiple jobs. And you must have seen this kind of a things when you organize a large conference. Large many people they work together under one head. And that's what I exactly said during the inauguration ceremony is I'm not a single crystal transducer. I have got a multiple crystal who works together in these training programs. And they're the faculty, the local organizers, and multiple patients. When you come for a hands-on, then you realize that 140 patients coming up, 150 patients coming up in 4 days' time. And they are lying on a table. All of us are doing echo on them. And they're guiding you. Doctor, put your probe over here. Here you'll find a better image. And this is the difference between linear phased array and a harmonic transducer. I'll try to show you again. Look at this linear phased array. Look, you can't see apex clearly. And same patient, now you can see apex clearly in the same subject. Look at the apex very clearly seen with harmonic induced transducer, and it's not seen with the harmonic transducers. Then technology has moved very fast. It's a cutthroat combination. Now we are not using linear broadband phase array transducer. We are using linear broadened multi-planar phase array transducer. We are having a line of piezoelectric crystals. Now these piezoelectric crystals are not there in long axis, but they're in short axis also. And they're firing, and the single beam is formed, and then it spreads out. So the imaging quality is extreme. And that's what is a matrix crystal transducer as on today. And it's give rise to 3 dimensions, X, Y, and Z. Axial, elevation, and azimuthal planes to give you this kind of images, which were not seen long back. And this is what the technology has changed over a period of time. We can look for 3 dimensions images, all 3 views together in one plane. And we can get an online ejection fractions of these subset of populations. How much is my ejection fractions today is. Another one, we can really get the depth of these patients of evaluations of echocardiography. But when we talk of images at the basic level, we have to understand 3 different planes. First plane is long axis plane. Put your hand on your chest, feel your apex beat. Draw a line right from apex beat to your right shoulder. Apex beat to right shoulder, that is the long axis plane. Just go to the center of your heart. Draw a line from a left shoulder to your right hip. That is your short axis beam. And now put your hand just parallel to your heart. That is a 4-chamber or a frontal plane is. If I'm doing echocardiography, when I'm touching my left tip of the heart or the apex to right shoulder, I'm doing my long axis views. If I'm doing a short axis view means left shoulder and right hip. That is short axis view. If I'm parallel to my heart, look, I have to be parallel to my heart like this. So I'm doing my 4-chamber plane. I'll show these examples over a period of time. Remember long axis, remember short axis, remember 4-chamber planes. Now this is the cut section, what I said to you. So this is long axis. This is short axis. If I'm cutting the heart like this, this is 4-chamber planes. Every transducer has got an index marker. Either it's a light over here or an indent over here. And this index marker, what we'll be talking again and again, where to keep my index marker when I'm doing what view I'm doing this. Now comes position of the patient. All of us understand when we lie down on the left side of our chest, our heart comes closer to my apex. And that's what facilitate for doing echocardiography is. This is what an image from our own department. Here is a person who's lying on a bed with left turn with the index marker over here. This is the index marker of the probe. So this position is known as left lying position, and first view is left parasomnal window. So what he is doing is apex beat to right shoulder. So what he is doing is long axis view. Index marker at facing 11 o'clock position, and he has to be in left second intercostal space to drive the first left parasomnal window. So we do what? In adult, we start with parasomnal windows, left parasomnal region, apex region, subcostal, suprasternal, right parasomnal region. However, we become reverse. We start with subcostal window in pediatric population, then come to apex, parasomnal, suprasternal, right parasomnal region. So these are the positions of the probe. One is left parasomnal region, left second intercostal space. Apex is apical is fifth intercostal space. Subcostal subxiphoid place. Right parasomnal, right third intercostal space, and suprasternal in the suprasternal fossa. So we'll be showing you all these images one by one. So we remember we have 5 positions where we keep our transducers. Now, everybody in previous courses, they get really scared. How many views in parasomnal window? 1, 2, 3, 4, 5, 6, 7, 8. My God, all these views has to be done. They're very simple. They look bigger, but they're not the one you should be afraid of. When we do a long axis view, then we rotate our transducer some position in short axis view, then we RV or inflow view, then pulmonic artery flow view. In apical positions, we have 4 chamber, 2 chamber, 3 chamber, and 5 chamber view. Then comes subcostal region, 4 chamber view, IVC, and short axis view. Suprasternal, we have ascending, descending, and arch of aorta. Then we have right parasternal and right anterior oblique view. Let's start with plaques view. Left parasternal border, feel your chest, where is your left parasternal border is. Then feel your third intercostal space. Close to sternum, and the index marker of the probe is 11 o'clock positions. And you get plaques view straight forward. So let me show you. This is what the index marker, third intercostal space closer to chest, index marker facing 11 o'clock position, and this is the hip apex, and this is the right shoulder. So what we get is parasternal long axis view. And in this parasternal long axis view, these are the various views. Look, here is the image. Index marker kept in left third intercostal space. Here is a person. Here is a machine. Look, what we are getting is a left third intercostal space. Index marker, left third intercostal space, index marker facing 11 o'clock positions. And here you get a views seen over here is plaques. You can see this view over here also. This is a plaques view. So what we get is RV free wall, RV, anterior aortic root, posterior aortic root, right cornicus, non-cornicus, interventricular septum, posterior aortic root in continuation with AML, LA free wall in continuation with posterior wall and mitral valve. Look at the place. Look at the position, how these views are made. We have recorded the live recording, and here the views comes. Here's the image what we get. Here's the image which we are labeled over here. And this image tells you lot many things in one go. RV, interventricular septum, anterior interventricular septum, LV. Then this aorta, right cornicus, non-cornicus, then interior part of aorta is in continuation with interventricular septum, posterior wall with AML, LA free wall with the posterior wall and PML. And here is a descending aorta. So all things can be seen over here. And every views carry an importance. For example, suppose I've got a proximal LED lesion. This basal anterior septum is supplied by D1 branch of LED. A person in clinical practice, you must realize that many people, they come for acute anterior MI. Some of them, they behave well with thrombolysis. Some of them, they do not behave well with thrombolysis. How do you differentiate? This view, this basal anterior septum is supplied by D1 branch of LED. Mid anterior septum is supplied by D2 branch of LED. Suppose my D1 branch is obliterated or not working or not contracting, it means my lesion is before the D1 branch, that is left LED origin. Suppose my lesion is, this is contracting, mid anterior septum is not contracting. It means my lesion is a mid LED lesion. If both of them are contracting, the apex is not contracting, the lesion is distal LED lesion. So if I happen to see a proximal LED lesion or partial lesion of LED, these people are full of thrombus and clot. Medical therapy is not going to work. The time is essence, shift a patient to cath lab facilities. If both of them are contracting, then very simple. Just do a thrombolysis. You know the lesion is distal to LED lesion, mid LED lesion. And that's how we make a lot of difference in clinical practice. Then, same positions. Now the footprint is looking toward mediastinum. Now look at this probe. This is index marker, that was Plaque's window. Now the footprint is looking toward mediastinum. They're going back straight. Footprint is looking towards mediastinum. Correct. And when we turn to mediastinum, the footprint, we get RV, RA inflow view. Very good, useful view to calculate TR jet gradients. Look at it carefully. Straight Plaque's view, third intercostal space, index marker at 11 o'clock position. Instead of perpendicular, this probe footprint is looking towards mediastinum. And we get RV, RA inflow view. This is what the RV, RA inflow view is. This is RA, this is RV, and this is tricuspid valve. And if you get a TR jet gradient, one of the windows is for RV, RA inflow view. I'll go back and show you again. I'm not in a hurry, neither you should be in a hurry. This is Plaque's window. The footprint has started looking towards mediastinum. And what we get is a RV, RA inflow view. And this is what the RV, RA inflow view is. Now we get from long axis, we move on to short axis. What is the short axis? We were in same third intercostal space. Our index marker was facing 11 o'clock position. I rotated the transducer 90 degree. So index marker has come to 1 or 2 o'clock positions. Now look how we come back from Plaque's to short axis view. Look carefully. This is index marker at 11 o'clock position. Correct? Rotate 90 degree at the same position. Let the footprint look toward aorta. So RV, parasol short axis view at aorta. Then the footprint looking toward the apex. So we have aorta, mitral valve, papillary muscles, and apex. Look carefully again. And we get 4 views in this. One is aorta in the center. Then this is tricuspid valve. This is tricuspid inflow. This is proximal RVOT. This is distal RVOT. Then there's pulmonic valve, pulmonic artery which bifurcates to right and left. Here is left atrium, here is right atrium, here is the interatrial septum. This is the aorta in the center. Left coronary artery from here, right coronary artery from here, no coronary artery from here. So this becomes right coronary cusp, this becomes left coronary cusp, and this becomes non-coronary cusp. The footprint, which was looking towards aorta. Now look, the footprint is looking to aorta now. Yes, it is aorta. Now it start coming back. The first will come mitral valve, then come papillary muscles, and then come apex. So here is the aorta. Here is the mitral valve. So we have the mitral valve AML, PML. And then comes papillary muscles, the lateral papillary muscle, the medial papillary muscle. This is interventricular septum, and this is RV. And finally comes the apex. I'll go back and show you all the views which you need to look at it. Now look at this view. Rotate 90 degree, footprint looking toward aorta. Now the footprint is mitral valve. Then papillary muscles, and finally the apex. We get 4 views in that. This is a view where we look at what? We look at the coronary arteries. Left coronary artery, right coronary cusp, left coronary cusp, and the non-coronary cusp. We look at interatrial septal defects over here. We take a TR jet velocity. We look at the pulmonic flow velocity in this particular view. So parasol short axis view at aorta. Then we go to papillary muscles level. Mitral valve level. This is what the view used for calculating mitral valve area in mitral stenosis. This is lateral commissure. This is medial commissure. This is AML. This is PML. Then come papillary muscle. This is lateral papillary muscle. This is the medial papillary muscle. This is interventricular septum, and this is RV. And finally comes the apex. When everything is gone away, we have the interventricular septum and the right ventricle over here. So if nutshell, what all views you have to remember is, let me go back to my initial slide. It talks of parasol long axis view, plaques, short axis view at aorta, mitral valve, papillary muscle in apex, and RV, RA inflow view. Forget about pulmonic artery at the moment. Moving from plaques window, now we move towards apical window. What we do in apical window is, we take our transducer, instead of left third intercostal space, go to the apex. And how do you understand where the apex is? In male subject, put your hand in the apical regions. Wherever you find the apex beat, put your transducer over there. You started with 3 o'clock position, 11 o'clock position, rotate it to 2 o'clock position. So let the 2 o'clock position be over here. And you should be as parallel to the heart as possible. Need not perpendicular. You have to be very parallel. Parallel means like you put your hand on your chest. So the slice should cut in a parallel fashion. What do you get in this particular phenomena is, now look, this is what the third intercostal space is. Apical beat, like 2 o'clock position, and we are as parallel to the heart as possible. We are not perpendicular. We are parallel to the heart as possible. And what we get is, we get 4-chamber view, and very important view. This is apex, this is septum, this is lateral wall, this is AML, this is PML, this is LA, and this is descending aorta. This is RV, tricuspid valve, and RA. They don't come labeled over there. You have to label them by yourself. So apical 4-chamber view means we have 4 chambers seen in this apical window. So that's why we say apical 4-chamber view. This is apical 2-chamber view. I'll just tell you how to do it. Rotate your transducer counterclockwise. Now from 2 o'clock, we try to go back to 1 o'clock or 12 o'clock position. So what we get, this is anterior wall, this is inferior wall. So in 4-chamber view, lateral wall had the papillary muscles. Now in 2-chamber view, the inferior wall has got a papillary muscles. And finally, we rotate further counterclockwise, and what we get is the posterior wall and anterior septum. And this is the aorta. And look carefully, what is this view is? This view is a plaques view. Only fact is this location is in apex, correct? And that's what I was trying to show you in my live demonstration. Look, from plaques window, I slide my transducer to apical window. So this is 3-chamber view. Rotate clockwise, you'll get 4 and 2-chamber views automatically. So in case you can't make a view in apex, go to plaques window, same 11 o'clock position, slide. This is what you get is 3-chamber view, then 2-chamber view, and finally 4-chamber views. So we have 4-chamber, we have 2 chambers, and we have 3 chambers in the echo labs. Now, what is the importance of these 4-chamber, 2-chamber, 3-chamber? Why can't we have 1 chamber? All of us will understand our heart is a 3-dimensional structure. Our heart is not a single slice. It's not a piece of a bread. So to assess all the walls, we have to look at 4-chamber view, 2-chamber view, and a 3-chamber views. Now look at this 4-chamber view. Let me explain. This is septum. In 3-chamber view, this will be anterior septum. So we have septum. We have a lateral wall in 4-chamber view. AML, PML. This is LA, this is aorta. This is RV, this is RA. The important thing is the 4-chamber view, mid and basal septum is supplied by RCA. Mid and basal lateral wall is supplied by circumflex. And apical septum is supplied by LAD. Similarly, if you have 2-chamber view, mid and basal inferior wall is supplied by RCA, and rest all is supplied by LAD. 3 of this, 1 of this, 4 segments. If I rotate counterclockwise, mid and basal posterior wall is supplied by circumflex, basal anterior septum and mid anterior septum are supplied by LAD. LAD supplies almost 8 segments of the 16 segment of the heart. We do not have apical anterior septum or apical posterior wall. So in gist, these are the 3 views which we utilize in day-to-day practice. Now, what is other utility of these views? Look, we can calculate mitral stenosis gradients, diastolic function evaluations in this 4-chamber view. We can look at a diastolic function of RA. We can look at the tricuspid regurgitation jet in this particular window. And when we rotate counterclockwise, what we get is a 3-chamber view. We look at this as LVOT. So we take an LVOT flow velocity in this chamber. And then we have aortic flow velocity at aortic valve. We cannot be much parallel than this in any other view. And that's what we utilize as apical 3-chamber. Moving from 3-chamber, we go to subcostal window. We left our index marker at 11 o'clock position. We come back to 3 o'clock position over here. And look, this subject is showing an index marker. Again, we are parallel to the heart, as parallel to the heart as possible. Here is the index marker. So what he is doing? From 3 o'clock position, he is going back to 11 o'clock positions as we were going in apical windows. So this is what is going to counterclockwise rotations. Same patient who was lying on left decubitus position now is flat on his back with the folded legs. And we put a transducer almost parallel to the heart, as parallel we were doing in 4-chamber view. So we do a subcostal window. And what we look in this? We look at RV, RA, free wall. This is RA, this is RV. This is interatrial septum, good for ASD. And once we rotate counterclockwise, we open up the IVC. And this IVC measurement, just distal to hepatic vein drainage, is an ideal source for a volume conditions. 20 millimeters, 21 to be precise, which collapses more than 50%, 21 becoming 12, 10, then we say RA pressures are normal. If IVC is dilated, it means it's more than 21 millimeter. If we have a volume status, this IVC size is less than 13 millimeter in size. And who else can give you better window than this in subcostal window? So one, we look at RV, RA, then we look at intraatrial septum between left atrium and the right atrium to look at ASDs. Then we rotate counterclockwise to make it as subcostal subxiphoid view to look for IVCs. And this is where we put our measurement for an IVC. So we can measure this IVC before inspiration and after inspiration, how much collapse is happening in this IVC. Next is suprasternal window. Now, this is a very precarious window. Index marker at 1 o'clock position. Here is the index marker. And this is here the aorta, ascending aorta is. Here the descending aorta is. So we just keep in the suprasternal positions. And left turn will give you ascending aorta. Right turn will give you descending aorta. And this is how the images looks like. This is ascending aorta, arch of aorta, and the descending aorta. And we could see a left subclavian artery originating from here, left common carotid, and innominate arteries. So we have ascending aorta, arch of aorta, descending aorta. Here is the left common, it's the left subclavian, left common carotid, and then the innominate arteries. You could see much better clear over here, 1, 2, and 3 over here. Right parasternal window, like we are using the same left parasternal window, we use right parasternal window with the index marker at left shoulder. Not at your level, we can skip for some time. So 2D echocardiography is the backbone of echo. All studies are done in reference to the dimensions echo. Once we drive a 2D echo, we go for M modes and Doppler findings. And whenever we do echo, everybody asks ejection fraction, the so-called magician word of echocardiography. And we calculate ejection fraction by modified Simpson's biplane method. I've seen many people calculating ejection fraction in Plaque's view, 70%. Look, ejection fraction is 52 to 50, 60%, not 70%. So what we do is we go end-diastolic dimensions in 4-chamber view. Then we take a length that give you a volume. Then we go to end systolic area into length that'll give you ejection fraction in 4-chamber view. Same thing we do in 2-chamber views. That'll give you ejection fraction in 2-chamber view. And whenever we talk of ejection fractions, we talk of biplane, 1 plane, 2 planes. Then we talk of Simpson's. Simpson's is area length method. And when we modified the Simpson's area length method to multiple diskettes, as if we are putting one carom board to other and carrying the volume of individual carom board, those buttons, so that we get a total LV systolic ejection fractions. So method in 2025, what we use is modified Simpson's biplane method for calculation of ejection fractions. Look, male more than 52, females more than 54. So I can tell you right now over here, you always overestimate yourself. Males are not masculine. Females are more masculine than males as far as ejection fraction is concerned. And this definition has been trying to revise for a long time, not yet in the guidelines. Possibly the new ejection fraction will come as low normal is 57 to 68. And for female is 58 to 69. Even though the ejection fraction will change, the females will still dominate than the males, as far as the low normal ejection fraction is concerned. This is a pictorial diagram of my LV segments. This is four chamber view. This is septum and lateral. This is four chamber view. This is two chamber view, anterior inferior wall, and this is three chamber view. So in four chamber view, apical septum and apical lateral wall, apical inferior wall and apical anterior wall, along with mid anterior basal anterior septum is supplied by LED. If I move further, my mid and basal lateral wall, mid and basal posterior wall, as in short axis view, is supplied by circumflex. And last is I have a right coronary artery, mid and basal septum and mid and basal inferior wall. It is supplied by RCA. So in nutshell, this blue color represents circumflex, mid and basal lateral and posterior wall. This dotted red color suggests RCA, mid and basal septum and mid and basal inferior wall, and rest all apical segments of four chamber, apical segments of two chamber, along with mid and basal anterior wall, and two segments of mid and basal anterior septum are supplied by LED. Look carefully in 16 segments. Two of this RCA. Two of this is circumflex. 8 segments are supplied by LED, and now you can expect a person who develops extensive anterior wall MI, he normally comes in a shock. Similarly, we saw the papillary muscle in the lateral wall. We saw the papillary muscle in the inferior wall. If we have a lateral wall papillary muscle, it means circumflex. Majority of these people, they come back with breathlessness because papillary muscle dysfunction will happen and they have severe MR. If the patient has got inferior wall MI, they often come with a shock because if the inferior wall MI is before the origin of RV branch, so they have RV which is hypokinetic. So that's how we number of times recollect or remember like which artery is possibly involved. And the management exactly change. And you will see in your practice patient with circumflex lesion, they'll not talk of a chest pain. They'll talk of a breathlessness on exertions. And that helps you in making a diagnosis. Many people, they don't only talk of 16 segments, they always talk of 17 segments only. Now this is a bullseye diagram. This is a LED, mid and basal anterior septum, basal anterior wall. Mid anterior septum, mid anterior wall. And here is a basal anterior wall. Then RCA, not basal anterior wall only, but apical septum, apical posterior wall, and apical lateral wall. This is not apical posterior wall, this is apical inferior wall. So apical septum, apical anterior, apical lateral, and apical inferior wall. So almost 60% of the 50% of the area is supplied by LED. Mid and basal septum, mid and basal inferior wall, RCA. Mid and basal posterior wall, mid and basal lateral wall is supplied by circumflex. This is what you can remember all the times when we talk of LV segments abnormalities. Some people, they talk of 17 segments. What they did, they renamed the nomenclatures and including apex as a separate segments. But I would request you to follow 16 segment model because of the reason majority of machine, they talk of even 16 segment model as on today. What is the best method for looking ejection fraction? This is a picture from our own lab. LV opacification with myocardial contrast echo. We inject a myocardial contrast into the right arm. In comes and opacify the left arm. And that's what the myocardial contrast echo is. As I showed you, a couple of things is, we do a fundamental versus harmonic imaging. The quality of image becomes much better. And if you had harmonics with contrast, you get much better images other than that. This is an echo gimmick. This is a model which is showing you like how the LV contracts. The 3 dimensions echo ejection fraction. Look, the most important part of 3 dimensions ejection fraction is it gives you end diastolic volume and systolic volume, and it gives you contractility. But at the same time, it gives you the most important point is how these segments are contracting with systole. Are they contracting at the same time or different time. That's what we call as synchronicity. This cannot be done without a three dimensions echocardiography. And synergy is how much LV is contracting. So 3D echo gives you a global ejection fraction in terms of end diastolic and systolic volumes. Synchronicity and synergy. Synchronicity is very important in patient with dilated or ischemic cardiomyopathies. One more word before we take up your questions. Myocardial performance index. This is indirect measurement of LV functions. How do we do it? We just put a sample volume at the mitral valve. We get mitral inflow. Wait for some time till systole happens. Then we get another sample volume. We look at a mitral valve closure and opening time. That is A. LVOT ejection time. That is B. And divided by LVOT ejection time, you get myocardial performance index. This is a very important factor in people who are having poor LV systolic function. Because this is not dependent on anything. In one go, you're getting everything of systole as well as diastole. So it gives you a value for myocardial performance index. Normal value is about 40.45. Anything less than that is considered as normal. Higher the value, poor is the LV systolic functions. So I'll put here my talk at this present moment, stop it over here and start taking up your question answers one by one. I'll request raise your hands so that I'm able to reply comfortably to all of you. Dr. Tajinder Kaur.
Hello, sir.
Go ahead.
Hello, sir. Regarding the position of the pointer in apical four-chamber view, in which position we put the pointer at 3 o'clock position or toward the patient shoulder?
3 o'clock positions. Our best answer, Tajinder, is to put your probe at 2 to 3 o'clock position. Feel your apex beat. Put your transducer over there with as parallel to the heart as possible at 2 to 3 o'clock position.
And sir,
In the
in subcostal position, position of the
same 2
pointer
to
is the
3.
same
2 to,
3 o'clock.
same 2 to 3.
Okay. Thank you, sir.
Dr. Shabaz Kareem.
Hi, sir. Good evening.
Good
Sir,
evening.
my question is that you had just demonstrated the supply of coronary artery in four chamber as well as in the three chamber view, sir. In three chamber view, as you explained, sir, in three chamber view, the inferior and as well as the anterior wall, lateral wall. So the supply is a bit different in such scenario, sir. Can you explain this, please, again, sir?
I think the best answer is I'll go and show my slides. This is three chamber view, right?
Yes, sir. Yes, sir.
So this is anterior septum. This is posterior wall.
Okay, sir.
Anterior septum has got two division, basal anterior septum, mid anterior septum.
Okay, sir.
This is supplied by LAD.
Okay, sir.
Posterior wall is supplied by circumflex, basal posterior wall, mid posterior wall. They were supplied by circumflex.
Okay, sir.
Important issue is in this three chamber, the basal anterior septum has got a dedicated supply by D1 branch of LAD.
Okay, sir.
Mid anterior septum has got dedicated supply of D2 branch of
D2
LAD.
LRD. Okay, sir.
So these branches help us in identifying where the lesion in LAD is. If my basal anterior septum is contracting well, mid anterior septum is not contracted, it means my D1 branch is open and the lesion is distal to DVM branch of LAD. Correct?
Correct, sir. Correct, sir.
What is your roll number, Dr. Shabazz?
Sir, my roll number is I think 5 in
Online 6. Online 6.
no, only in online, sir.
Only on online number 6.
Yes, sir.
Okay. All right. Any other question, Shabaz?
No, sir. Thank you, sir.
So we are done with Dr. Tajinder, and then we have Sharmeen Sultana from Dhaka. Sharmeen, go ahead.
Assalamu alaikum. Sir, can you
Walaikum salam.
hear me?
Yes, I replied you, Sharmeen.
Sir, thank you, sir. Sir, if it is dextrocardia, what will be the proposition?
Just revert it up.
Okay,
So
sir.
if it's a dextrocardia, look, I did not say those words. If I'm doing echocardiography, believe my word, the first thing I'll ask patient is what is his ECG is, what is his X-ray chest is. And I often offend my patient, why you have come to my lab, man? He often says, I have no problems. I said, if you don't have any problem, what is the problem of coming to this place? Then he'll start opening up. I've got a pain chest, I've got a cough, I've got a breathlessness. So if you look at a patient, look at his history, look at his X-ray chest, look at his ECG, and then you start doing echocardiography. So first answer is, if it's dextrocardia, you will find his X-ray chest is rotated already. Correct?
Yes, sir.
Now your index marker for plaques position would be right third intercostal space, index marker at 2 o'clock positions. Patient will not be lying on right, left hand side. Patient will be lying on right hand side.
Okay.
Similarly, apex position would be right fifth intercostal space with index marker facing where? Same 2 o'clock position.
Sir, I can't understand. In case of apical fourth chamber view, where will be the index marker?
In
At lateral or
dextrocardia or
medial side?
pneumocardia?
Dextrocardia, sir.
In dextrocardia. Now, look at your apex beat. It will be on right hand side. Patient will be lying on right hand side. Correct?
Okay.
So,
yes, right hand side.
slide
Yes.
your transducer from the same positions which you made in right personal window. Where your index marker was in right personal window, left shoulder. Correct.
Yes.
You slide the transducer to the
Yes.
apex position. What you will get is 3 o'clock positions. Rotate
Yes.
clockwise and go back to almost 11 o'clock positions.
Okay, sir.
You will get the same window on the right hand side in dextrocardias. Subcostal window,
Okay, sir.
your index marker would be reverse. It will not be at 3 o'clock, it will be at 12 o'clock positions. If it's a situs inversus. If it's not situs inversus, then same 12 o'clock position because heart is inverted already.
Okay, sir.
Right, Shamin?
Yes, sir. Thank you, sir.
Thank you. Dr. Narayan Surwase.
Yes, sir.
Go ahead, Narayan.
Yes, sir. How to obtain a very good image? Most of the times I am keeping my probe in a particular position. That is correct. Even marker is correct, but we doesn't get a proper echo image.
Please do not laugh. I'll tell you how to get a good images. Do your wife give you lunch to carry along with you?
Yes.
Give that lunch to one of the good persons who have got a very good echo window. Let him sleep on a couch and do every day 1 to 2 hours echo on the same person. Two things will happen. He'll sleep and snore. And in 1 month time, you will start getting excellent windows. It is a practice which make you perfect. And that's why a word said, don't laugh. I used to do the same thing while I was working in US. I used to do my night duties. I used to get a coupon for lunch and I used to give it to one of the person in the department who was always fond of eating something. So he'll have a lunch, he'll come and sleep, and I'll do an echo for 2 hours on him. So once you become perfect to make various views, then you start doing those things to your patients. And approximately 40% of the patient will have good windows. 60% of the patient will have horrible windows. So once you develop a confidence in doing a good echocardiography in a normal subject, your confidence will build up automatically over a period of time. Is the practice, practice, and practice. And I always quote this word. You must have gone to casino. The more you play, the more you win. Here I say, the more you do, the more you learn. So it's a practice which will make you perfect. Dr. Parashar said very adequately, nobody reads. Science is changing so much every day. Amazingly, a different world is happening. We cannot cope up with those development and changes. Even if we read 10% of that, that's more than enough. And since you have taken a dip into this holy language or holy echocardiography, you have to come out really with flying colors. Successfully, you should touch the best of echocardiography.
Thank you.
Dr. Priya Brata. Priya, go ahead. Can you hear me, Priya?
Good evening, sir. My name is Priya Singh, sir. Sir, I just wanted to, can you please, sir, explain me
Priya,
myocardial
first of all, you should get a
performance
very good internet
index
connection.
once
You must have a
again
very good
and
internet connection.
its advantage, sir, please.
I can't listen to your voice is getting scattered completely. And unmute yourself and then you speak slowly.
Good evening, sir.
Good
My
evening.
name is Priya. Sir, can you please explain me myocardial performance index once again, sir,
Okay.
please?
Okay. You can see my slides, Priya? All right.
Yes, sir.
So we have put a Doppler spectrum pattern across mitral valve by pulse wave.
Okay, sir.
So what we get is a mitral inflow in a form of E wave and A wave. We
Yes,
wait
sir.
for the next beat to come, that is E wave and A wave. As you understand, the mitral valve will open during diastole, then the systole will come, and then the diastole will come. So we measure a time interval between mitral valve closing and opening time, that is A time. Then we go to three-chamber view. We look at a pulse wave at a LVOT. We try to look how much is the time the blood flow from LVOT, that is beginning of LVOT or flow, and the end of LVOT flow. This is A time, this is B time. A time divided by B, minus B time divided by B time will give you myocardial performance index. Normally it's
Okay,
about 0.45. Higher it means poor LV systolic function. Lower it means good ejection fractions.
okay, sir.
And we will come back to it again and again. When I'll talk of LV function, I'll come back to this again.
Okay, sir.
Right?
Okay, sir.
Right. So we have now again Dr. Deepak. Deepak, you want to ask something more, or you can lower your hand by yourself?
Sir, good evening, sir.
Good evening.
Sir, you told apical chamber, fourth chamber view at 2 o'clock or 3 o'clock position, sir. Anti-clockwise, we have to like I did get sir that one, like anti-clockwise how to get two chamber and three chamber view.
What I mean to say is you put your probe on a chest in left fifth intercostal space with the index marker at 3 o'clock position. Correct? Let me
Yes,
show that
sir.
slide again to you. Give me a second.
Yes, sir.
Now this is at 3 o'clock position index marker. Correct?
Yes, sir. Yes, sir.
Now from this index marker, you rotate this probe counterclockwise like this. Now
Yes,
look,
sir.
it'll start rotating. Have you seen this?
Yes, sir. Yes, sir.
So this is what counterclockwise rotation is. What
Okay, sir.
my submission is, you start at 11 o'clock position, slide your transducer in the same 11 o'clock position to the apex. So what
Yes,
will
sir.
happen? You rotate clockwise to get the two chamber and three chamber. But at your answer is I'll hold the probe when it comes to apical window.
Okay, sir.
This is what the apical window is. We are as parallel to the heart as possible. Index marker at 2 to 3 o'clock position. We are trying, my footprint is touching the chest. And with this touching of the chest, now we'll rotate counterclockwise. Look,
Yes, sir.
now is rotating. But you have to keep contact with the chest.
Okay.
All right?
Okay, sir. Okay.
You can lower your hand. Anybody else have some questions? Can raise your hands. Now, initially, it looked to be a very difficult task. I'm sure 5% people will disappear by next class. 10% by the end of first module. Dr. Muhammad Ismat.
Hello, sir. Good evening. Myself, Dr.
Go
Mohammed
ahead.
Ismail. Sir, I wanted to know what is leading edge and trailing edge, sir?
We'll come to measurements. You're a good echocardiographer, I know about it. Wait for some time other people to understand it. Dr. Shantanu Parmod Mal.
Hi, sir. Good evening again.
Good evening.
So when it comes to the PSAX view,
Okay.
how do we change from the aortic level to the mitral level? Like the footprint, how does it exactly go?
Okay, I'll show you again.
Yeah.
See this? You know who, like when the student asked me this question, I said, let me record it. And that's how I made it. Now look, now we are going from plaque. Go back to the slide again. Now this is plaque's window, left third intercostal space, index marker at 11 o'clock position, right? Now he'll rotate 90 degree. Done. He'll rotate 90 degree. Hold. So once you rotate 90 degree, so at third intercostal space, what is the structure seen normally? Mitral valve. So at this point, if you are cutting, now you are becoming almost perpendicular. Here almost you are perpendicular. So you are cutting mitral valve, so you will get mitral valve images. Now look at this footprint which looks toward aorta. Aorta is over here. Correct. The footprint has seen towards aorta. Now footprint will start coming back towards mitral valve. So it is mitral valve. Now footprint from mitral valve, which is perpendicular, we now start looking gradually towards your left hip, slightly towards left hip. This is papillary muscles. And finally, it's looking to your left hip. This is what? Apex.
Apex.
So first picture is aorta. Second picture is mitral valve. Third picture is papillary muscle. And fourth picture is apex. Now look at this picture again carefully. Rotate 90 degree. Footprint towards aorta. Back to mitral valve. Back to papillary muscles. Back to apex. Now that's how the movements are happening. Clearly? Are you comfortable now? Is that okay? Dr. Priya, go ahead. Dr. Priya, let's have the pleasure of seeing your face also. Go ahead. Ask a question. Unmute yourself. Unmute yourself. Let me try to unmute you.
Sir, can you listen me?
Yeah, I can listen you. Go ahead, man.
Sir, how to find out apical three-chamber view from apical four-chamber view?
That's what I showed you. Apical 3-chamber view to 4-chamber view. Let me just show you that video again.
Yes, sir. You have shown.
Now look at this video carefully. Right? This is 4-chamber view. Index marker at 2 o'clock position. We are parallel to the heart. Now we'll
Yes, sir.
rotate counterclockwise to make it 2-chamber view. Counterclockwise, this is 2-chamber. Further counterclockwise, 3-chamber. And look carefully. See it again. Four-chamber.
Yes, sir.
Rotate counterclockwise, 2-chamber.
Yes, sir.
And then rotate further counterclockwise, you'll get 3-chamber view. And this position would be same as the index marker is at 11 o'clock positions. Now it'll come back to the same 11 o'clock position. If you can't make your good views, go to apex window, slide your transducer toward the apex. You will get apical 3-chamber view. Do a clockwise rotation, you get 2 and 4-chamber views.
Okay, sir. I'll try it next day.
Yeah, go ahead and try. Then you'll find it better answers.
Okay, sir.
Great. You can lower your hand. Dr. Muzaffar Naik from Srinagar. Dr. Muzaffar, go ahead.
Yes, sir. Good evening, sir.
Good evening.
In the subcostal view, can you re-explain how to assess IVC volume?
Now look at the subcostal window. We are parallel to the heart and like index marker at 3 o'clock position. We rotate counterclockwise. Then we open up the IVC. See this video again. I'll fix it up. No. 3 o'clock position. Now we are almost parallel to heart, slightly towards right hand side or right shoulder. We are not in the center, slightly towards right hand side. So we rotate counterclockwise, the IVC will open up. And this is 4-chamber view. This is subcostal 4-chamber view, index marker at 3 o'clock position. Rotate counterclockwise, your IVC will open up. And you have to measure your IVC distal to the hepatic vein junction. This is hepatic vein to IVC. This is IVC opening into the RA. So many people, they measure over here, but the recommendations are you measure where IVC joins the hepatic vein, and then you measure before inspiration and after inspiration. Is that okay?
Thank you, sir.
I know this is too much of everything today, but we'll send you the video recording of this. Go and look at the video recordings. Practice for a week. Ask me any questions. The WhatsApp group would be open all the times. And those who will really work hard, believe my word, you'll find the fruits. Those who hardly works, no way. The only difference of hard and hardly, LY. Go ahead, Dr. Kamal. Unmute yourself. Ask your question.
Yes, sir. Good evening.
Good evening, Kamal.
Yeah.
Yeah,
It's happy to
100%
see-
audible.
Yeah. It's happy to see you after Bareilly CME, Bareilly workshop. I met you there.
Sure. Chandosi.
Yes. Sir, you explained in a view that we go below D1 branch or D2 branch. Then you explained the time to thrombolysis. That part was
My
missing.
question is, yeah, go ahead. First you speak, then I'll answer.
That was, I think, missing from my side. If we are going from basal to mid, the thrombus is downward somewhere, then we are planning to thrombolysis after looking in echo. So
No, my quest of saying that was, if you are doing an echocardiography in a patient who has presented to your hospital with acute anti-wall MI, so how do you understand this patient is of high risk or low risk?
okay,
Whether we should immediately go for intervention or we go for thrombolysis.
yes,
Suppose your patient, you did an echo, his basal anterior septum is not contracting, is not thickening. It means the lesion is before D1 branch of LED. So it means it's a proximal LED lesion. And whenever we have proximal LED lesion, the whole of the LED is full of thrombus. So these patients, they collapse very fast. I can quote an example of the same thing. I taught the same thing in previous batches. I said if you happen to see ST elevation V1 to V4, and you do an echo, you find basal septum is not contracting, you start your basal management and shift a patient to a nearest possible cath lab center. So when they started this, the BP was 120/80, the heart rate was 80. In next 30 minutes time, the heart rate was 120 and the BP was 80. And they did an angiogram, and you sent that patient saying that this patient has got a proximal LED lesion. They did an angiogram and they said the same thing. Look, this patient has got a proximal LED lesion. And they opened up the vessel, patient survived. Right. Now it did a second presentation is patient presented with chest pain, ST elevation. You saw your echo basal anterior septum is contracting and mid anterior septum is not contracting. It means your lesion is distal to D1 branch of LED. Correct? And if you have a facilities for good thrombolysis, BP is maintained, you do a thrombolysis. Fair chances is patient will survive. Third answer is, you have anti-wall MI, your basal anterior septum, mid anterior septum, both of them are contracting. It means your lesion is distal to D1 branch, D2 branch of LED. Oh, forget, relax, man. Do a thrombolysis. This guy is going to survive.
Thank you, sir.
That's how I interpret in my life. Another answer is we always look at mitral regurgitations. Correct? We measure mitral regurgitation jet velocity. And this question is addressed to anyone who's doing echocardiography over here. Even the basics of echocardiography. What should be the mitral regurgitation jet velocity should be to call that patient BP is 100 millimeters of mercury. If you go to the ICU, sister has only two values. Pulse rate 80, BP 120 by 80. Whatever it is, the BP will never go up. The pulse rate will never go up. MR jet velocity will give you a gradient between LV and LA. Suppose my MR jet gradient is 5 meters per second. By Bernoulli's equation, 5 into 5 into 4, my BP is 100 millimeters of mercury. If you have an LA pressure of 10, my systolic blood pressure is 110 millimeters of mercury. And that's what we utilize in CSU. If I happen to do an echo of a patient with any CAD, want to assess his blood pressure, I always look at NMR jet. If my MR jet is 3 meters per second, you know how much is my blood pressure? 36 millimeters of mercury. The patient is shocked. Sister will say patient is all right. So that's what the hemodynamic effects of echocardiography is. That will learn over a period of time. In Plaque's view, you must have seen my RV is very small in size. Let me share this Plaque's view again. Look, this is my Plaque's view is. This is LV, this is RV. If I happen to see this RV has become as good as LV, it means what? My RV is large. It means I'm dealing with some kind of a right-sided pathology. Similarly, if you look at a short axis view, look at this short axis view. This is LV, this is RV. Look at this interventricular septum. Normally this septum bulges towards RV because my LV pressure is 120 and RV pressure is only 25. When it starts becoming D-shaped, it means the RV pressure is trying to equalize LV pressure. And when systolic contraction, this interventricular septum bulges towards LV, it means my RV systolic pressure is more than LV systolic pressure. I don't have to calculate anything in the world. So my quest of showing these basic images is, look, we are not talking of big things. Just look at the image, what exactly is happening. Every image tells you something. And it is your eyes which has to pick up those images. And we always call a word WHY, Y syndrome. Why this is happening? And if you utilize your brain and do critical analysis, you will find the answers. And if you are a physician, believe my words, this modality is of immense use for a physician. Immense. When you come to hands-on, then I'll show you how different these echo images makes up in your clinical practice. It's a long journey. I'm sure when I started doing echocardiography, you were not born. 1986. I sold off everything of my household, went to US to learn echocardiography. House, car, and everything. And you guys are lucky. You know, what is 80,000 rupees today, man? I sold off my car, house, and everything and went to US to learn echocardiography. 1986, I went over there. Dollar was 25 rupees only. And the people used to come from world over to learn echocardiography in Thomas Jefferson University Hospital. And I used to live 140 kilometers away. I was the first person to open the department at 7 o'clock and the last one to leave in the department in the night, 8 o'clock. Because I was there to learn. I was not there to enjoy. So spend time. You don't have to go anywhere, not even one step outside of your house. Dr. Shantanu, go ahead.
Yes, sir. I remember you having said something about, there were graphical representation of the LV wall cavity, I think, at different levels with the interventricular septum and certain color codings with respect to
Yes,
the.
Shantanu, I said was interventricular septum gives you tons of values. Interventricular septum decides about your pressures. My LV pressure is 120, my RV pressure is 25. As the RV pressure starts building up, getting close to 120, the septum start becoming flattened. When the RV pressure becomes more than LV pressure, the LV interventricular septum will bulge into LV during systole. And that itself tell you, if I've taken my blood pressure is 120, I'll say RV systolic blood pressure is more than 120 millimeters somewhere. We'll show you over a period of time. All right.
Right. Also, sir, with respect to the blood supplies, there was a slide wherein, the posterior wall, you were saying something about with respect to um, whether it's the papillary muscle rupture or the side.
Correct. So if you remember, 4-chamber view has got a papillary muscle on the lateral wall.
Yes, sir.
2-chamber has got a papillary muscle in the inferior wall.
Right.
Lateral wall is supplied by circumflex.
Right.
And majority of time, circumflex artery is bigger than right coronary artery. So if you have papillary muscle ischemia, so what will happen to papillary? If you have a circumflex ischemia, it transforms to papillary muscle ischemia. And when ischemia will happen, you'll find mitral regurgitations.
Right.
So these patients, instead of presenting with chest pain, they will present because of MR as breathless on exertion.
Okay.
And a very simple way of looking at them. Patient is lying on the couch. He shows mild ischemia. Ask him to walk for certain distance, come back, lie. You'll find a torrential MR. Give him a sorbitrate. The torrential MR will disappear right in front of your eyes.
Right.
Very clinical things which we do in day-to-day practice. All right. So you can lower your hand. At least one more person is standing in the line from an online group. I couldn't see his number. Can you unmute yourself and speak? Go ahead.
Sir.
Yeah, go ahead.
Sir, kindly repeat the proposition of RBRA inflow.
RBRA inflow is you put your plaques window in plaques window, Shamina. We let the footprint looks towards media sign. Let me show you that window again. Plaques window.
Yes, sir.
Now this is plaques window and now footprint is looking towards mediastinum.
Till the probe.
I don't say tilt the probe because tilting a probe is either from this side or this side. I say let the footprint look toward mediastinum.
Okay, sir.
All right, Shamini?
Okay, thank you, sir.
Thank you. Dr. Subhashish Das.
Good evening, sir.
Good evening, Subhashish.
Yes, sir. Actually, while we advise echo in our hospital, in patients with COPD and all, the report comes as poor echo in window, and they give inference that we could not analyze the patient nicely. So, what would be your take on this, sir?
Dr. Subhashish, what do you understand by word idiopathic?
Without any cause.
No, in medical terminology is when doctor is idiot, patient in pathetic condition.
Okay.
What is issue in subcostal position is my heart has become horizontal. That's all. Subcostal window will give you everything.
Okay, sir.
Only thing is you cannot measure proper measurements.
Okay.
And ask me this question when we are doing a hands-on sessions.
Okay, sir.
I'll demonstrate you everything in subcostal position. And that is the best position you can ever have. Give me a patient with a COPD. I'll get you everything because heart has become so closer to the abdomen so that all parameters can be calculated very easily.
Okay, sir. Thank you, sir.
All right. So I'll just quickly take your attendance before I close the session. I could see I've already marked the people who asked the question. So I'll just say them they were present. I saw that Muzaffar Naik, number 1, was present. Dr. More Abhijit Magan. Is he over here? More Abhijit Magan. Dr.
Yes,
Dev,
sir.
you're present. Okay. The roll number 3, Dr. D. Navakant. Dr. D. Navakant. Unmute. All of you can unmute yourself. Dr. D. Navakant. Dr. Shiva Kumar.
Sir.
Dr. Chirag Gurbani.
Yes, sir.
Mahua Roy. Mahua Roy. Dr. Deepak asked the question already. Dr. Pratik Rajesh Shah.
Yes, sir.
Dr. Ramavatar Sharma.
Yes, sir.
Dr. Madhu Saini.
Yes, sir.
Dr. Prajakta Uday Pote. Row number 12.
Yes, sir. Yes, sir.
13 is Dr. Sushma Kirti Kumar Gaurav. 14th is Dr. Major Kiran J. G.
Yes,
Kiran
sir. Yes,
G.
sir.
15th is Raghavinder
Present, sir.
Vikram Bhagchand, 16 number. Vikram Bhagchand. Dr. Lovedeep Seni.
Yes, sir. Present.
Dr. Rijul Seni.
Yes, sir. Present.
Dr. Gaikwad Anshuman Jai Singh.
Yes, sir. Present.
Dr. Mal has already asked the question. Dr. Tajinder Kaur has asked the question. Dr.
Yes, sir.
Lavkesh Singh Parihar.
Yes, sir. Present, sir.
Ravi Shankar GS.
Present, sir.
Abhishek. Dr. Abhishek.
Present, sir.
Dr. Chandrakant Patil. Dr. Chandrakant Patil. Ashish Rathore. Dr. Ashish Rathore, number 26. Dr. Renu Dohan, 27 number. Dr. Renu Dohan. Dr. Kamal Kishore has asked the question. Dr. Deepika Joshi.
Present, sir.
Dr. Shankar Gowda.
Yes, sir.
Dr. Subhashish Das asked the question. Dr. Madhav Bansal.
Yes, sir.
Dr. Yogesh Bang. Yogesh Bang. Dr. Chaitanya Bujbal. Dr. Chaitanya Bujbal, 34. Dr. Muhammad Ismat asked the question. Dr. Priya asked the questions.
Yes, sir.
Then Priya Raghavendra Singh. Dr. Priya Singh also asked the questions. Dr. Ravi Kumar Nimala. Ravi Kumar Nimala. Then Dr. Satyam Lekha.
Yes, sir. Present.
Dr. Tejasvi Mathur. Tejasvi Mathur. And the two more online people were there. Can you name yourself one by one?
Sir, I'm
Anybody
Sharmin
else?
I'm also present, sir. Sharmin Sultana, online 5.
I was Sultana, you asked the question, you are already marked present.
Okay.
I'm noting down everybody who's asking the questions. So tomorrow you'll find your attendance, you'll find your name already over there. Attendance as well as question asked by. Anybody else left?
Yes, sir. Hello, sir. Good evening. This is Dr. Mohua Roy from Kolkata.
Dr. Mohua Rai, you are on online, Dr. Mohua?
Yes, sir.
All right.
Dr. Navkant, sir.
Dr. Navkant, I've called your name already. Just as what is your roll number, Dr. Navkant?
3, sir.
Yeah, when I called you, you were absent. All right. Anybody else? Dr. Mawarai, your roll number is 7. You
11.
are in 7.
Okay.
You can check your number again. This
Yes.
is
Yes,
number
sir.
7. And I'll request everybody to name yourself with drop /51 /April 25 /October 25 /roll number. I'll send you a WhatsApp so that you can create everybody names comes up automatically along with their roll numbers. So absents today are, one is Dr. Vikram Bhalchand, then Dr. Yogesh Bang and Chaitanya Bujbal, Ravi Kumar Nimala, Tejasvi Mathur. All right, guys, have a good day, good night, and study something for next week. I'll come back to with the measurements so that what you apply in day to day. I'm not going to take a long number of measurements. I'm going to take a very small number of measurements which you like to use in your clinical practice. With these words, I would like to say you stay safe and see you next week. Bye-bye.
Thank you, sir. Good night. Thank you, sir.
Good night, sir.
Good night, sir.
Yes, sir. Good night, sir.